All right, let's get started. It's Thursday. We're over the hump. Everything is downhill from here. Today is going to change out a little differently from what's on your agenda. I'm going to start with a couple of cases, and then we'll do. I added a little unit on chest pain and primary care, and a little unit on assessment and impression. So I'm going to be doing this stuff till 10. My colleague Dr. Gutman will be here at 10, and then at 11 we'll walk over to the neighborhood health station. That's about the plan. So at least, somebody had talked about getting us a bus. I don't know whether that's actually happening or not, but I think we all decided that we could make the walk if we needed to. Good for us. All right. This is going to be our most difficult day in some ways, because this is the day when we cover the things that we're going to make mistakes about. These are the things that are the places where we all get trapped. And if we're ever going to make dangerous and difficult mistakes, it's going to be about the stuff I'm going to talk about today. And so the idea is, the thing I learned in preparing for this is the stuff not to be heroes about. This is the stuff to sort of play it by the book, because if you don't, this is where we get into trouble. This is where things are ambiguous and confusing. So, a couple of cases. 70 and these aren't made up cases. These are the real ones. 78-year-old Spanish-speaking grandmother complaining of back pain. When you show up on scene, she greets you with cupcakes. Her pulse is 88, her respiratory rate is 12, her blood pressure is 170/92, her saturation is 98, and her temperature, she's afebrile. The folks who go on scene aren't Spanish speaking, so they call Dr. Sam because it looks like it works. Dr. Sam speaks to her in Spanish and says, "Bring her over." You bring her over, and 30 minutes later you get called back, because she's in the middle of a BFMI, and obviously she gets run to Miriam and they fix her from there. But this is the challenge of chest pain in women, or the challenge of heart disease in women, which often doesn't show up as chest pain. This is one that can fool anybody. Go ahead.
What's the BF and MI?
It is not polite.
Okay, that's what I said. He asked what it was. That's what I said to him. I'm like, I'll ask.
39-year-old psychiatrist who's unconscious with agonal breathing. He had a hernia repair a week ago, and now he's, like I said, unconscious with agonal breathing. I don't think it's very hard to figure out what you're going to do. But what happened? Anybody know? Outside of the fact that he died, or he's dying.
Some of those benzos.
I'm sorry?
You got in some of those benzos he prescribes.
Yeah, actually not. He has a big, in this particular case, the clue is in the hernia repair.
Yeah, no. Bleed.
Excuse me?
Internal bleed.
Nope. He had a big saddle pulmonary embolus in the middle of the night and died. Just nothing from a hernia repair. Pulmonary embolus is going to turn out to be the thing that kills people that you're not expecting, because it doesn't show up in the way that you expect it to show up. Healthy 39-year-old guy, like I said, all he had was a hernia repair. Happens after hernia repair is you sit around, and when you sit around, you form clots in your legs. I'll talk about pulmonary embolus a little more. 35-year-old tree surgeon with a sudden severe headache. This is a guy who fell out of a tree 2 years ago. He has multiple fractures. He has chronic back pain and chronic headaches that he's always complaining about, but this is different. Pulse 102, respiratory rate 16, blood pressure 150/90, 98 and 98. He's got a headache. What are you gonna do?
Call you guys.
I'm gonna take him to the ED.
Why call us and why take him to the ED?
You guys go first.
Right.
And I'm gonna take him to the ED because his history, and he just doesn't feel the same. So I'm gonna go ahead and skip you guys and just go.
And you're gonna be right. Here's why. Sudden severe headache. Sudden severe headache. And the words people will use is, this is the worst headache of my life. I'm the guy who always has headaches, but this is different. And what did he end up having? Anybody know? An aneurysm. And it was beginning to leak and was getting ready to rupture. They actually got him into the OR in time. They clipped the aneurysm and he is alive and well today. He said, man, they wanted to let me, sort of sit. My wife wanted to blow me off, and I said, you cannot do this. This is like nothing I've ever felt before. And that saved his life. Otherwise healthy 35-year-old guy, like I said, was alive and well today because he wouldn't let his wife tell him what to do. No, I didn't say that. 62-year-old with high blood pressure and cough for 1 day. She's obese. Pulse is 92, blood pressure 150/92, respiratory rate 14, temperature 98, sat 98. Question about whether she's got a little edema, but her legs are big and beefy, and you can't really sort out whether she's got swollen legs or not. So all she's got is a cough. So what do you do? Sorry?
You guys.
Give us a call. We say yes. You bring her over. Doc looks at her. She looks okay. Can't find anything. He gives her medicines to help her not cough at night so she can sleep through the night. And she wakes up 2 days dead. What happened?
Overdose.
Sorry?
Just a pot failure.
Nope. No, her lungs were clear. Anybody else? She had a pulmonary embolus. Just another pulmonary embolus. There was probably a big clot sitting in her leg, but you couldn't tell it. It let go in the middle of the night. That feeling of a cough or tugging in the back of her throat was the first piece of embolus that pulled off. But she didn't explain it in a way that anybody could understand it. Dead as a doornail. And that's the kind of thing, this is where we're going to run into problems from time to time, and we're going to screw some of this stuff up. It's part of the way we have to live this life. And so the thing we do is we talk to each other and we try to be careful. And it's, remember, the patient is the one with the disease. Nobody in this room caused the disease. Our job and our opportunity is to figure it out where we can and try to get in front of it. 47-year-old weightlifter who smokes complains of sudden severe tearing or ripping chest pain after lifting. Now he's short of breath and diaphoretic. His pulse is 178/100. His blood pressure is 178/100. His pulse is 110. Respiratory rate is 16. Temperature 98. Saturation 98. What are you going to do? Go to the ED. What's going on? I'm sorry? No, it was a good idea. Well, not a pneumothorax, but it's a good thought.
Maybe a rupture or something, because you're describing it with tearing pain.
Rupture what? Good pickup.
Triple
Aortic. He's got an ascending aortic dissection. What's going to happen to him? Exactly. What's the mortality rate of an ascending aortic dissection? Mortality rate. The survival rate is 5 to 10%, so the mortality rate is 90%. Almost everybody who gets this dies. This is, surgically almost impossible to repair.
My cousin had it, it's been living 5 years.
He is one lucky man. And of the ascending aorta or the descending aorta?
I think it was ASAP.
The ascending ones almost never make it. The descending ones,
I had a 5% chance, that's all I know.
if you had a 5% chance, that was ascending.
5
He
years
is,
ago.
he is one lucky guy. You know, he's a guy I want to go out for drinks with and I want somebody
Yeah, he
to
won't go
rub off on me.
drinking. He ain't drinking.
Yeah, I'm not saying that he should be drinking, but 65-year-old Hispanic female with a headache and high blood pressure who just ran out of meds. Her blood pressure, she has a history of high blood pressure. Her blood pressure today is 178/100, pulse of 88, respiratory rate 12, again 98. All she's got is a headache. What do you think?
How long without meds?
About 3 weeks.
Probably
Going to you.
YED. All right, it's a fair call, and, you know, conservative, I'd rather go conservative than not. If you call us, we're probably gonna say yes, because we know her, and she always lives sort of in the 160 to 178/100. We haven't been able to get her down, so, you know, we will probably take her and work on changing her meds. If the same number was 186/110, and that puts her over to the hospital, and I'll talk about that in a little bit. But this is somebody with chronic high blood pressure who just didn't take her meds, and we're gonna be able to play around with their meds and fix her. The ED is gonna do the same thing we do, only, you know, we have actually a little more experience working with people with chronic high blood pressure.
She got the same symptoms as the guy that fell out of the tree, though. Like, how do you discern what's going on?
Well, the difference is the guy that fell out of the tree is saying, this is the worst headache of my life. I never had anything like it. And she's saying, I got a headache like I kind of have headaches all the time.
Oh,
And that's where this is tough. But it's this is something different than I've ever had before that I think is always worth listening to. You know, and there's no disaster to go to the ED. You know, if somebody needs the ED, I'd rather err on the side of caution.
The problem is gonna arise is when we start being second guessed for our decisions, because you're putting us in the position of making decisions. And we're gonna make mistakes. We're gonna go to you when we should have go to the, you know, ER, and we're gonna go to the ER when we could have went to you. The problem is gonna be if we start becoming liable for those things, because it's just as easy to take everybody to Miriam and skip you altogether.
I get
Just
that.
off the hook.
I get
So we
that.
have to find a way, you know, we have to find a way to make this work.
I hear you. Well, that's kind of why we're here, sort of going through this. Most of the stuff that comes to us is going to be, you know, pretty cut and dried. It's going to be the, you know, sort of vaginal discharges and the, you know, kind of cough and runny nose kind of thing. That's the stuff that probably ought to come to us.
Yeah.
And, you know, this is something we're going to get used to a little bit over time. And we're going to, you know, the good news is we have the opportunity, you know, to make it work by making sure we're talking to each other. And you know, we're putting, you know, I want to say over and over again that the guys in the field are the guys who make the call.
So as long as nobody's looking at this and saying, hey, you guys went there, and then you had to go back and take her out of there, and, you know, like grading us like we made a mistake or something.
No,
They're judgment calls, and that's all they are.
They're all judgment calls.
Right.
And you know, everybody's got to respect that on both sides. And I think everybody will. That's why we're trying to be here and talk to each other. 65-year-old Hispanic male with a cough for a day. It's December 26th. This is a smoker, status post-MI, a couple years ago, who got revascularized with high blood pressure and diabetes. Blood pressure 160/90, pulse 92, respiratory rate 20, you know, temperature 98, but saturation 91. RALS on pulmonary exam and bilateral edema. What do you think? ED, what do we got?
Her O2 sat is 91.
I'm sorry?
Her O2 sat is 91.
You got
It's
it.
not on your criteria, less than 95 goes to
Right.
ED.
Good call, but what do we got?
CHF.
I'm sorry?
Sounds like CHF.
You got it.
Right.
So, pretty straightforward, but always worth talking about. And when we get to the little bit on high blood pressure, we'll sort of talk about how this and that play together. All right, let's see if I can get this working. So, people in primary care look at chest pain in a pretty different way than you guys do, and with good reason. What you guys are worried about is the person who's in the middle of a big MI and needs the ED right away. Most of what we see isn't that. Most of what we see are other causes of chest pain. And those include gastroesophageal reflux and peptic ulcer disease, musculoskeletal chest pain, cardiac pain, pleurisy, pericarditis, psychiatric causes of pain, pulmonary embolism, and aortic dissection. But when we think about people in a certain way, we think about it in the same order that you guys do. We always want to think out cardiac first, because the first thing we want to do is identify a cardiac cause and get that person moved to the ED if we need to get that person moved. The answer is usually, for us, and I'm not suggesting that you guys do this, the answer for us is almost always in the history. Remembering that angina is a 5-minute chest pain, usually relieved by rest. It's usually more discomfort than pain. It's usually exercise associated, or when it's exercise associated, that feels more diagnostic. There's often radiation to the left shoulder and jaw. It's usually described as band-like or crushing. Sometimes people will say it's an elephant sitting on their chest. It feels sometimes like it's burning or heartburn. It doesn't change with position. There is sometimes sweating associated with it. It is not reproducible when you press on the person's chest. That's the first thing I do, is to see if I can reproduce the pain if I press on the person's belly or chest. Because if I can reproduce the pain by palpation, it very likely isn't heart-related pain. It's not ruled out by a normal EKG if the pain isn't present. So what always happens in my life is the medical assistant who brought the patient in the room hears the word chest pain, does an EKG, but the pain's not there, and so the EKG is normal. And then I say, okay, EKG is normal, it doesn't help me much. The EKG helps me only when the EKG is markedly abnormal. That tells me that I've got some heart disease, but I think that happens, I'll see that twice a year, where there's a markedly abnormal EKG that I think is related to the problem. But it doesn't mean that I don't want to, and we don't get a cardiogram on basically everybody who says the word chest pain, pretty much the way you guys do. I think the 12 lead really helps, but it really helps only when it's positive. It doesn't rule anything out when it's negative, and that's a thing to keep in the back of your mind. And in women, it's less classically described. Often it's chest pain that comes on with rest or sleep or stress, and it's often not specifically chest pain. It's often like shoulder pain or back pain, or just I couldn't get comfortable. The challenge for all of us is to understand the way heart disease presents in women, which is really different than how it presents in men, because we miss it in women an awful lot. Oops, I went the wrong way. And obviously, the AMI story. The duration is minutes to hours, often diaphoresis, nausea, vomiting, feeling of impending dread. As I said, women have silent MIs much more commonly than men. The EKG is positive if diagnostic, and doesn't rule anything out if it's negative. What we do in the office when we see somebody who we think's in the middle of cardiac-related chest pain is we slap them on oxygen, If the chest pain is present and we can find one, we'll give them a nitro. We don't always keep nitro around, so often it's one of us rumbling through somebody's purse trying to find their nitro. We give them aspirin, which we usually have, and we call you because you guys are, from my perspective, the short-term definitive treatment. When I walk in and see those SDT waves through the roof, oxygen and call 911. That's, do not pass go, do not collect $200, let's get going. And that's all I want to do, because that's my job, because the people who are going to treat the patient are the people in the cath lab. And all we can do is get the person to the cath lab as quick as we can. As you're walking out the door, I'm calling whichever hospital you're going to and giving them a full report, so they know what they're getting, and they know what they're getting from my perspective. And you're calling them too, so hopefully they're ready when you walk through the door. But whenever I send, and this is true of all my colleagues, whenever we send anybody to the ED, we pick up the phone and call the ED. So hopefully the ED knows what they're getting. And I don't know if, from what I was hearing yesterday, you're not always met with great enthusiasm. I'm hoping that our calls sometimes make a little difference. Any sense of that? Do you get a flavor for, if we've called ahead, or no sense of that?
I've never had an instance where, like, just take for example like Chestnut Street, where the doctor's like, oh, I'll call Miriam and give a report. When we get there, we have no sense that they've received report or anything.
They talk to somebody, but not in the ER. They don't talk to anybody that we initially talked to.
Yeah, actually, the people we get to talk to are triage, and they take report from us. And what I'm hearing is that our friends in triage don't talk to the nurses who bring people through the doors, and that might be something that I can have a couple of conversations about, because I'm not sure that the people who run the ED know that. And I think I'm guessing that it would feel a little better to you guys if you walked through the door and so somebody said, "Oh, Mrs. X, well, we knew she's coming. Pull her right in here," because that makes your job a little easier, right? All right. A lot of the way I think about this is to start with risk factors, and those are smoking, diabetes, obesity, family history, stroke, hypercholesterolemia, and to a certain extent high blood pressure. We've argued about the high blood pressure piece over the years, and I think we're finally agreeing that high blood pressure is probably a risk factor for heart attacks and angina. It's certainly a risk factor for stroke. When we started treating hypertension, it wasn't to prevent heart disease. It was to prevent stroke. That's the strong association. But it is fairly rare to see somebody who doesn't have any risk factors with an MI. It happens, but it's pretty rare. Mostly, you can tell just off the risk factors almost alone. So the next thing we think about is peptic ulcer disease and reflux esophagitis. That's also burning, but usually more burning in the epigastrum. Usually it lasts hours. It often improves with eating. It's associated with nausea and burping, but not sweating or restlessness. It doesn't have that feeling of impending dread that people who are in the middle of an MI will talk about. There's associated epigastric tenderness. This is a place where if you press on the person's epigastrum, you're going to replicate the discomfort. So, if I'm listening to a story and it doesn't quite sound like heart disease, I'm going to press on the person's belly because I want to know if they get uncomfortable. Because if they get uncomfortable, then I kind of have a pretty good idea of what I'm dealing with based on where they're uncomfortable. And this kind of problem is usually easily treated with an H2 blocker like Tagamet or a proton pump inhibitor like Prilosec, but it usually takes a couple of weeks for it to really calm down of daily medication. And then it often recurs, particularly in people who have traveled out of the country because of an infection with a bacteria called H. pylori. And so often we'll treat people, we'll treat them for a month, they get better, they get happy, and then 2 or 3 months later, they're back and they say the whole thing started again. And then we test them for H. pylori. Anybody know what the treatment for H. pylori is? 3 antibiotics for like 2 weeks. It's not fun treatment, but most of the time we can get rid of the H. pylori and then things settle down.
What's H. pylori?
H. pylori is a bacteria that, and it's the bacteria that causes most ulcers. When they first discovered it, I didn't believe that it was a real thing, but it's been now conclusively proven, and is the source of most of this problem. And it's frequently, there's plenty of it that circulates here, but for some reason it circulates more commonly in other countries. So that people who've traveled out of the country will come back with this. And, you try to treat them once with Prilosec or Tagamet, and, you get a little improvement, and then they're back, and then you have to go through the whole rigmarole. And it's not a fun it's not a fun rigmarole because it's so many antibiotics, and it makes people, the antibiotics make people feel funky for a little while. So, is what it is. Musculoskeletal pain often is radiating pain from a thoracic paraspinal spasm. That is to say, people's back hurts right kind of in their thorax. And you find that out by pushing on the big muscles that lie next to the spine. And it turns out to duplicate some of their chest pain, which kind of, they'll say kind of comes around when you push on. Treatment for that's physical therapy. And then rib pain often is a cause of chest pain. Anybody know the difference between a bruised rib and a fractured rib?
Yeah, nothing.
It's exactly, well, nothing except for the break. But in terms of symptoms, it is the exact same pain. And the difference turns out to be 3 weeks. A bruised rib gets better in 3 weeks. A fractured rib gets better in 6 weeks. You know what you got to do to get a fractured rib to heal? That's exactly right. You put both ends in the same room. That's what we always say. That as long as it's there and you give it 6 weeks, they're going to heal, but they're going to hurt along the way. And in the days when we are more careful about opiates, people often have a long time before they get really comfortable. But it is a frequent cause of chest pain. Intercostal muscle pain, the muscles between the ribs, often can get strained or messed around with, and the pec major is often a source of pain. And the musculoskeletal pain stuff is suggested by a history of either recent trauma or change in exercise routine or new exertion. So painting a house, if you haven't painted before, doing a bunch of new lifting, or using loppers, the things you use to take down branches. People who start doing that will often come in with pec major pain. And, this is where, a 38 or 35-year-old with new chest pain that's bilateral is a whole different ballgame than a 58-year-old with diabetes who's a smoker who comes in with chest pain. The diabetes in the smoker says, think about their heart first, because that's about likely where we're going. So pleurisy and pericarditis are inflammation of the lining of the lung or the lining of the heart. They are not very frequent, but they're not totally uncommon. They don't present with tenderness when you press on them. But you make the diagnosis essentially by stethoscope. There are characteristic sounds or pains that are in one place and or change with position. So it's from listening and by getting people to shift around and seeing how the pain changes. And these almost always respond to aspirin or ibuprofen. And they are outpatient treatment, but hard to know about when you're in the field and somebody's complaining of chest pain. Somebody's complaining of chest pain, that's the ED, till proven otherwise. This is mostly to kind of give you some background to what we do when somebody walks through the door and what we've gone through before we call you. We've kind of walked through all these paces, and the only time we're going to call you is if we can't rule out myocardial disease. An ascending aortic dissection, as I said, is relatively rare, 2 to 3 per 100,000. Watch out for weightlifters who smoke in their 40s. It's this sudden onset of severe tearing pain. And the reason that happens to I assume that there's nobody who's a weightlifter in their 40s who smokes, but just saying, be careful, because what the smoking does is it actually damages the inside of the aorta and sets you up for tearing the damn aorta when you increase your intrathoracic pressure when you lift. So that's what happens in, and that's what to be careful of. It's this sudden onset of this terrible pain, and this is just a scoop and run, and as we said, 90 to 95% mortality if the dissection is in the ascending aorta. If the dissection is in the descending aorta, it's more like a 40 to 50% mortality. But the weightlifters get it in the ascending aorta, and they don't do well. So be careful. And stop smoking if you're smoking.
Stop yelling at me.
I was saying that kind of generally, not to any one particular person. Pulmonary embolism is chest pain that's usually worse with breathing. It sometimes shows up as that tugging in the throat. There's often shortness of breath, but hypoxemia, but there doesn't have to be. And this is where pulmonary embolism is the disease that scares primary care doctors and emergency room doctors together, because we know that we will get fooled by it, and we'll get fooled by it over and over and over again. And it's now probably the single most common cause of sudden death. Used to be that big MIs were the cause of sudden death, big MIs and atrial fibrillation. But in my lifetime, I've seen the real change in the prevalence of heart disease. When I was a medical student, when I was a resident at Memorial, we used to admit people in flash congestive heart failure like 6 or 8 or 10 times a night. We'd fill the ICU with them, and we'd put them on low-dose dopamine and diurese them out and get them better in the morning. But those were all people who had totally destroyed their hearts from atherosclerotic heart disease, who had a couple of MIs and wrecked their heart muscles. And actually, you don't see that anymore. That's all gone with ACE inhibitors. And we're just better at preventing heart disease, and we're way better at treating it. So now pulmonary embolism is the thing you got to think about when there's a sudden death. It's the one to be feared. So it's way more common in smokers. Not that anybody in this room smokes. Obesity, people with sedentary lifestyle, or have a long plane trip. If you're flying to Hong Kong, they tell you to get up and walk around every 3 or 4 hours because of the risk of pulmonary embolism. It happens, occasionally on airplanes because of people just sitting there. Recent cancer is a major risk factor, and often when somebody has a pulmonary embolus, we start looking around to make sure there's no hidden cancer present, because it's a major predisposing factor, mostly because its effect on clotting. And as I said, recent surgery. Recent surgery is a big deal, mostly because people sit around too much. So if you yourself find yourself having some surgery, don't sit around. The bottom line is, or people in your family, get them up and moving as soon as you can. I have a teacher who's 97 years old and is in Boston. He's a guy named Dr. Bernard Loud. He actually won the Nobel Peace Prize in 1985 for doing some work around nuclear disarmament. But Dr. Loud described the modern treatment of heart disease. When I was a medical student, when somebody had a heart attack, we used to put them in bed for 2 weeks and keep everything really quiet. You actually weren't allowed to talk above a whisper in the CCU. And that was because we didn't want anybody to be disturbed because they were resting. And what Dr. Lown realized was they were resting so well that we were killing a fair number of them because we kept them in bed. They got blood clots. And those clots in their legs turned into pulmonary emboli and they died. And so now we get people moving around fast. And it's to prevent this dread complication. So, obviously, the EMS role is adults, according to our protocol, adults over 40 with chest pain are excluded. They go right to the ED, do not pass go, do not collect $200. Younger people, there are probably some judgment calls, but in the beginning I'd say go right to the ED. Don't play around if you have any doubt. There's sometimes you're going to walk in and it's going to seem like, not really. But I think let's put that up, moving even those guys to the neighborhood health station. Let's put that off a couple months till we're used to doing this, so you don't get into the sense of being stuck with a judgment call that you didn't want to make. But even with people who are young, particularly watch out for younger people who use cocaine, because cocaine itself can induce MIs. And then, as I said, people with heart disease who need to be, or those who need to be ruled out for coronary artery disease, walk into the neighborhood health station themselves occasionally. That's when we really need your help moving them to the ED, but please be assured that before we call you, we've run through that whole routine first, doing everything we can to make sure that they didn't need the ED from our perspective. And with that, we need to change the slide deck, so everybody, wasn't there, take 5 minutes and take a deep breath. One by one. We'll do a couple of these, and then I've got a little discussion about implementation, so we'll probably go through to about 9:30, take a 5-minute break then, and then do assessment. Primary care physicians devote huge energy to preventing heart disease and stroke. When you really look at what we do on the prevention side, a fair piece of what we do is to really try to prevent these two conditions. And it turns out most can be prevented by diet, exercise, and not smoking. I have a friend who's a cardiologist in New Bedford who thinks 80% of heart disease is preventable. And that means that we spend a lot of time talking to the people we take care of and just trying to bug them about not smoking, changing their diet, and getting 30 to 45 minutes of exercise a day. It's funny to have a job doing that. And that's because there's this whole sort of zone of what causes what. It's all kind of interrelated. So obesity causes high blood pressure and diabetes. High blood pressure causes heart disease, kidney failure, and stroke. Obesity causes diabetes and heart disease. Diabetes causes heart disease, vascular disease, and stroke. Hypercholesterolemia causes heart disease, vascular disease, and stroke. Exercise reduces weight and also reduces cholesterol. I think I forgot to say one of the what causes what as you go through, but it's all this big overlapping mess. And if you go back 30 or 40 years, you see how America has become an obese place. We now produce about 6,000 calories per person per year. And anybody want to know how many calories a day most of us need in 2018 if you're not, working out every day? 2,500, 1,500, probably more like 1,100. It's nothing. It's like 4 oranges or 7 Oreos. It's for those of us who like to eat a little bit, it's unfair. And it's really hard because there's food every place.
I probably eat like 7,000 calories a day. Like that's like on a low end. That's for breakfast.
Yeah, well, if you're eating 7,000 calories a day, the good news is that Amish farmers who are they walk 20 miles a day. By the time they're done, they're always throwing hay around and stuff like that because they don't use much mechanization. They burn 5,000 calories a day. But it takes that kind of exercise to be able to balance off the 5,000 calories. So everybody was taught about 2,000 calories a day or 2,500 calories a day turns out to be a lie. Most of it is because of money that got spent by the food industry to convince people they ought to eat more. So we all got convinced to eat more. We all eat more. Too many of us put on some weight, and that set us up for heart disease, diabetes, and stroke. And so most of my job is to try to push back against all the ads on TV and tell people that it stinks, but you can't actually eat very much, and then you got to exercise. This is primary prevention standing on one foot, and it is eat much, not too much, mostly plants, don't smoke, exercise 45 minutes a day, get 8 hours of sleep, hang out with people you love, and nobody ever got to 70 and said, gee whiz, I wish I had worked more. If I could get everybody in the United States to do this, or even everybody in Central Falls to do this, I would be put out of a job, and that would be a good thing. But that's basically all we're saying over and over and over again. We actually don't have much to offer beyond that when you get right down to it, except on the treatment side. So high blood pressure does damage over 20 years, not over 20 minutes. There's one exception, which is malignant hypertension, which is really rare. 1 to 2 people per million per year. So you just aren't going to see, in general, these massively elevated blood pressures of like 180 over 120. 180 over 120, I think we will throw in as an exclusion criteria because 180 over 20 needs the ED, but like I said, we probably see 1 to 2 cases of this in Rhode Island a year. Most people live in the sort of 170 over 110 range when they're really out of control. A typical high blood pressure is greater than anything greater than 130 over 80, and people keep arguing back and forth over whether the number is really 140 or 130 and really 90 rather than 80. But once somebody gets to 130 over 80, I'm going to start saying start exercising or watch your diet. I'm going to start harassing people when I see that. And high blood pressure less than 120 over 80 is never an emergency. The other thing that's really important about high blood pressure is this has been studied up the wazoo. High blood pressure is symptomless. You cannot tell when your blood pressure goes up. Your blood pressure doesn't cause headaches. People will often say my blood pressure is up and I have a headache. There's no evidence that says they really know that. They often have a headache and they have high blood pressure and they make the association. But and sometimes patients will get themselves all wrapped around the notion that I have a headache, so I must have high blood pressure. But it ain't true. And even so, as long as their blood pressure is lower than 180 over 120, it ain't an emergency. There ain't no way it's going to be an emergency today, tomorrow, or the next day, regardless of what the patient thinks. Usually these are little old ladies who are anxious, who decided that because they have a headache they must have high blood pressure, and that's an emergency. It ain't true. So how we manage typical hypertension, that is anything between 130 over 80 and 180 over 120. We start with diet, exercise, and smoking cessation. And usually we'll see people, we'll get people started and then check things again in a couple of weeks or a month, depending on how high the blood pressure is. Then we add drugs, and we keep seeing them once a month until we get their blood pressure down. And we start with the low dose, and then we start to turn the dose up. And once we max out one medication, we'll add a second. And sometimes we even add a third, though it drives me crazy to do that, because medicines are often more problem than they're worth. As we go, we're checking for kidney damage and electrolyte disorders. The medicines, like I said, are the problem. High blood pressure medicines often cause low potassium. And so we're really keeping our eye on the potassium. And it's the high blood pressure itself, sustained over 10, 20, 30, 40 years, that causes kidney damage. The most frequent cause of chronic renal failure is uncontrolled high blood pressure in diabetics. So diabetes plus high blood pressure is kidney disease, and that's what you got to watch out for when you have both. So we get people so their blood pressure is where we want it, and then we start seeing them less frequently. We'll drop back to every other month for a couple months, and if things are okay, then we drop back to every third month, and then finally to every 6 months to a year. There are a bunch of people walking around who have high blood pressure, have been on medicines for 10 or 15 years, and we just see them once a year because they're otherwise okay. And sometimes if we can get them to lose 10 or 20 pounds, we try to back off on the medicines because, like I said, the medicines are often as much a problem as they want. People get side effects from medications. That happens commonly. Low potassium, impotence, fatigue, headache, and cough are all common side effects of blood pressure medicines. So, it's always interesting to know if somebody shows up with one of those things, just to check on whether and the first thing I'm going to do is check on what medicines they're on. I spend now most of my clinical time in express care. I'm not doing continuity care anymore. So, I see people, who I've never seen before 12, 14 times a day. So I'm always checking in on these things to try to figure out whether the medicine is the right thing for them or not, or whether it's causing as much problem as it's fixing. So, one question I was thinking of as I was running through this is, do we need inclusion criteria for things like high blood pressure? I just ran out of medicines. I have high blood pressure and ran out of medicines. Now I have a headache, so I must be having a stroke. And my potassium was once low and it hasn't been checked in a while. Can you take me to the emergency department? Are these the kinds of things you run into, or is it just doesn't happen that much and we don't need to name them? What do you
Run out of
think?
medication.
Run out of medication is common?
It's
High blood pressure was a lot.
High blood pressure that, people say my blood pressure's high and it's just high and I need to go to the
Sometimes we
emergency.
get it from visiting nurses.
Right.
They'll tell us, this patient's high blood pressure's, this patient has high blood pressure, they need to go to the hospital. So then you get there and it's like 160 over 102.
Drives me crazy. So just a quick aside about the visiting nurse world. I highly respect visiting nurses. However, there are now 85 different visiting nurse organizations in Rhode Island. So there are a zillion of them. And that means, in general, one doctor or nurse practitioner or PA doesn't have a visiting nurse who they work with on a regular basis. So there's basically chaos out there. Usually what happens is somebody gets in the hospital, they get discharged, the hospital always sends the visiting nurse. The visiting nurse has never met the patient's doctor, and there is no organized conversation at all. We're trying to change that with the neighborhood health station. We have one visiting nurse organization that we're working with. It's called Nursing Placement, who are good and are also, they have the best set of non-English speaking staff that we've run into. So we're going to try to fix some of that, but you guys get some of the outflow of there's no organization in this thing. So the visiting nurse who walked in today is very likely to be somebody who's never seen the patient before and has never talked to the patient's doctor. So, anything can and will happen. We're used to that, unfortunately. But that's where, that opportunity, I think, is a great opportunity to have this conversation between You know, I mean, that's when calling over to talk to Dr. Sam might actually create some coherence. You know, because if your blood pressure doesn't show, you know, anything over 180 over 120, as far as I'm concerned, you know, the neighborhood health station is a perfectly good place for something that doesn't sound emergent to me. If it's just a, you know, the only hypertensive emergency over 180 over 120. Anything less than that, the blood pressure itself is never an emergency. This won't hurt anybody for 20 years. After 20 years, it will hurt people, but, you know, a blood pressure of 160 over 102, you know, is a blood pressure that just needs me to talk to the person and change their medicine. And it will not hurt them unless it's like that for 20 years. So, worth knowing. It will hurt them over 20 years. Actually, what I didn't put on the slide is the specific way it hurts people is, to me, a little interesting. Blood pressure like that, you know, sort of 160 over 102, sustained over 20 years, actually causes the left ventricle to stretch out and to get big and baggy. It produces its own congestive heart failure. And often what happens as a result of that congestive heart failure is that blood, you know, the flow of blood inside the ventricle slows down, and you get ventricular clots. And the ventricular clots kick off as emboli, and they turn into strokes. So, you know, this whole process of high blood pressure and the relationship between high blood pressure, heart disease, and stroke is high blood pressure that runs through stretching out the heart over years, because it's just making it work too hard for many years. Then causing a clot in the ventricle, and then the ventricle kicking off into a stroke. And I'll say this later, but, you know, I'll say it over and over again, that when somebody presents with a stroke, one of the things that people who are good look at first is they do a cardiac evaluation, because often you find left ventricular hypertrophy and that big baggy ventricle, or a couple of MIs. So one of the major risk factors for stroke is a heart attack, and one of the major consequences of a heart attack turns out to be a stroke. They often arrive together. But so when a stroke hits the hospital, first they treat the symptoms of stroke, but usually then they do a cardiac evaluation, because they run so closely together. But I'm going to take some of those as possible inclusion criteria. Actually, we took some of the discussion from yesterday and have drafted some new inclusion criteria. I'm floating it around with the people who are helping me think about this, and we will probably have a somewhat expanded set of inclusion criteria based on your input, because there are things that we want to take off everybody's back, you know, sort of like vaginal discharge, and high blood pressure under 180 over 120, which just is never an emergency, that we're learning about by talking. Anyway, headache is both common and usually not tricky, but occasionally very tricky. So I use typefaces to talk about what the common causes are. And I would say, based on experience, not based on any well-standardized study, I would say 97% of headaches are musculoskeletal. Most come from spasm in the supraspinatus muscle, or the muscles around the neck and the head. I get a great kick out of walking into the room with somebody with a headache and saying, I'm going to make this diagnosis with one finger, and I put the finger right on, you know, because I can sort of tell by looking at people, I can put my finger right on the supraspinatus muscle. That is, I can tell what side, and the person jumps and the diagnosis is done. One finger diagnosis, it's great fun because it's so common. So almost all is musculoskeletal. You can also have headaches from sleep deprivation, from influenza and other viral diseases, from migraine. There's something called cough-associated headache, because, you know, as you will think in your own experience, if you've got a cough that won't go away, and you cough and cough, eventually it begins to produce a headache. Sinusitis, but true sinusitis turns out to be exceptionally rare. Usually it's allergy causing sinus congestion, not sinus infection. Concussion causes headache. There's something called cluster headache. I don't know if you guys have run into that in the field, but it is a migraine-like experience that comes in groups and is actually treated with oxygen. And the oxygen usually just makes it go away. So one of the things you can do, if you ever have a question and you're moving somebody, is put them on O2 and see if that fixes the headache, as it will with cluster, though cluster is rarer than migraine, and true migraine is itself not overly common. Though almost everybody in America who has a headache thinks they have migraine headaches. But most people actually have musculoskeletal headaches. And you can get cold or MSG headaches. If you have ice cream on a hot day and eat it too fast, or if you have Chinese food, you get that really, sort of difficult headache, and that actually is from contraction of the vasculature. Your arteries contract, and that makes headache for reasons I'm not sure I understand. Less common are things like meningitis, aneurysm, subarachnoid hemorrhage, which has that sentinel headache that this is the worst headache of my life, or what's sometimes called a thunderclap headache. Suddenly comes on and is kind of just overwhelming. Stroke itself can cause headache. Brain tumor causes headache. It's rare, but it really does present with headache, but almost never only with headache. If somebody is worried about a brain tumor and they have nothing else, it's unlikely. Usually there's some neurologic findings associated with the brain tumor if it's big enough to cause a headache. But the thing to remember is, if it's a brain tumor, it's not immediately life-threatening. So a headache in somebody with a brain tumor, if a headache is caused by a brain tumor, it's nothing that anybody's going to be able to change right away, and it's not going to kill somebody in the next 8 hours, 12 hours, or probably not for months and hopefully years. And then there's a post-lumbar puncture headache. Have you guys ever seen any of those? They're not uncommon. Somebody who's had a lumbar puncture, a spinal tap, will get a spinal fluid leak in 20 to 30% of cases. And that causes people to have headaches the moment they stand up for the couple of weeks after the LP. And you fix that by bringing them back to the hospital and doing something called placing a blood patch. They draw a little blood and they re-inject the blood in the area of the LP, and that causes a little clotting and seals the lumbar puncture leak. So if somebody says, I just had an LP, then that's probably what's going on. So red flags, worst headache of my life, that thunderclap headache, which is kind of the same thing. All of a sudden it came on and I just can't get comfortable. It's like I've never felt anything like this. Intercourse associated headache, first episode. There are often headaches associated with sexual intercourse. And the first time it happens, somebody needs to go, no comment. Excuse me? Yeah, most headaches prevent intercourse. Yeah, that's right, I got a headache, right? Anyway, but the first time it happens to somebody, then they need evaluation, because some of those people turn out to be people who are, who've got an aneurysm or are working on a subdural. But then people who have had intercourse-associated headaches and have them all the time, that's nothing that's an emergency, because there is an association between intercourse and headaches in some people. I feel sorry for you. Visual changes, if you have a headache and somebody's having trouble with vision, to me that requires urgent evaluation. Often that's migraine. because migraine starts with funny visual changes when it comes on. There's what's called the migraine aura. But if somebody doesn't know they have migraine yet, you know, the visual changes associated with headache sometimes are things like tumors or MS or other new presentations of serious diseases. So visual changes in headache, you know, that's a red flag. A recent head injury suggests a concussion that may not have been recognized at the time of the concussion. Headache, fever, and rash. We keep showing this picture because of the risk of meningococcemia, that, you know, it kills people. And if you see it, it needs to get to the hospital and get antibiotics right away. Headache, fever, and delirium. And, you know, if somebody's not with the program and they have a headache, that's a red flag. And headache with any neurologic changes, somebody whose gait is unstable, whose balance is off, you know, who has trouble, you know, sort of putting their hand where they want it to hand or where they want it to be, or any kind of arm or leg weakness or slurred speech. Those are all red flags. Understanding again that 97% of headache is simple musculoskeletal headache that can be easily treated. So most of the time without red flags, not a problem. With red flags, take it seriously. And that's where this gets a tad tricky. So let's talk for a bit about stroke. And that's where you guys probably have more expertise than most people because you're on guard for it all the time. Defined as an acute neurologic injury caused by either inadequate blood flow to the brain from clot embolism or from shock, because once you drop your blood pressure, you stop perfusing your brain, and that functions as a way to kill neurons. That's 80 to 90% of strokes are from inadequate blood flow to the brain or bleeding in and around the brain from a blood vessel that breaks. That happens 10 to 20% of the time. Both poor blood supply and bleeding in the brain have the same outcome unless they are urgently addressed, and that's permanent neurologic damage and loss of function. In general, it's only the poor blood supply that we effectively can address. Bleeding inside the brain, we really don't have a good response to. But, you know, as I'm sure you know, we now have a couple of techniques to break up clots in the brain, from clot extractions to medications that break up clot. And of course, you know, stroke causes permanent neurologic damage and sometimes overwhelming brain injury and death. There are 80,000 strokes a year in the United States. We have about 2,500 strokes a year in Rhode Island. My rough guess, based on the numbers, is that we probably have 50 or so a year in Central Falls, though maybe a little bit less in Central Falls, because our average age actually skews a little bit younger than the rest of the state. And it's the 5th leading cause of death in the United States, so it's a real thing. And the opportunity is for those 50 is to identify them quickly, get them quickly to the hospital, get them to a stroke center quickly, and get definitive treatment. We actually do better than almost anybody else in the country at this. In part because people have paid attention and you guys have worked so hard on it, and in part because we are, there's relatively few places in Rhode Island that are more than 10 or 15 miles away. So our proximity really helps us be effective, and that we have, you know, now basically every hospital is at least a primary stroke center. So people are juiced up in general and pretty ready to go. Stroke, you know, the cause of stroke on the poor blood supply, on the cause side, poor blood supply, you get clot of arteries inside the brain, usually as the result of damage from inflammation and high blood pressure. Smoking really contributes to this. You can get an embolism from elsewhere to the brain. That's where high blood pressure really shows up as causing that big baggy ventricle, and getting a ventricular clot, and then having that piece of ventricular clot break off. That's what happens in atrial fibrillation as well. The reason we anticoagulate people who are in AFib, or some people who do it less than we used to because of the dangers of anticoagulation itself, but the reason people who live in chronic AFib get anticoagulated is because they're not getting regular ventricular contraction. They are the people who get ventricular clot, and they're the people, if you don't anticoagulate them, that clot breaks up and goes to the brain. And that embolism is also results from inflammation and high blood pressure because of that big baggy ventricle, and smoking, high cholesterol, and diabetes contribute to that, and shock, typically from a heart attack or another cause of acute blood loss. But when somebody's really bleeding out, you got to worry about their brain, and that's why that's part of why we push fluid so hard and so fast, because we want to keep their brains perfused at least enough so you don't lose neurologic tissue. Hemorrhage comes from worn out arteries that break. They get worn out from high blood pressure, from smoking, high cholesterol, and diabetes. So take good care of your arteries, please. You're going to need them, and the ones in your brain you probably need more than any other. Treatment, as you know, emergency diagnosis and treatment at a stroke center. Now, one thing that sometimes will get confusing but shouldn't have any impact on you is there's an entity called Bell's palsy, which is unilateral facial paralysis. It typically occurs in young people, and it typically is actually related to one kind of herpes virus infection or another. Sometimes it's related to Lyme disease. But
that'll clear up on its own, Bell's palsy.
it clears up on its own. It's not dangerous. It doesn't have big problems.
No, the herpes don't.
The herpes don't. But
I know that.
Yeah.
Once you get it though, you can't give it to anybody else.
When it's dormant.
No, once you get it.
Oh.
That's Bell's palsy. You can't give to anybody else. Not herpes. Anyway.
Now you guys tell me.
But I don't think that, to get to your point, I don't think that's ever your call. You see facial paralysis, and I think that just goes to
But
the
that would,
ED.
it mimics a stroke, but that could also come from a severe headache, like
A migraine.
migraine.
Not any severe headache. Migraine specifically is an entity of, sort of vascular headache. And there is this interesting and difficult overlap between migraine, headache, and stroke. So there are some migraines that show up and look, exactly like a stroke. One-sided, paralysis and slurred speech.
Correct.
But then they go to the ED, they get, treated, and actually just time passes.
It's an occipital migraine or something, right?
There are a bunch of different kinds, and then it goes away, which is the good news. But some of those things that start as migraines actually evolve into strokes. So this is remember when I started off saying this is the day of where we're going to talk about the things that we are going to stumble on. It's headaches that can be most confusing, and so that's where those red flags for headaches with any neurologic change, go to the ED. Do not pass go, do not collect $200, because I would rather err on the side of caution for stuff like that. The neighborhood health station is for coughs and colds, and just a little bit of a headache. It's not driving me crazy, but the ones that feel like they've got any neurologic compromise, or the ones that are the worst headache of my life, don't mess around. But that's why I thought it was worth spending a good part of a morning talking about all this stuff, because this is where it gets as complicated as it's going to get. Headaches and chest pain. Okay, I thought we ought to talk for a minute about influenza, given the time of year, and the way it often presents with headache. Because in the next couple of months, you're going to be seeing a bunch of it, and then it goes away, and you don't see it again until the following December or January. Have you guys been seeing much of what looks like flu yet? We haven't been seeing it at all. If if you ever are really bored and want to do something that only a policy wonk would do, if you ever go on the CDC website, they have a map of the nation. And they have different colors for each state based on what the flu activity is. And you can actually track influenza and the influenza epidemic, which always starts in the west and works its way east. So I can tell you with pretty good precision 2 weeks before we're going to have the flu epidemic here. And I looked at the map in the last couple of days, because I look at the map every couple of weeks. And there's a little activity in Massachusetts, but not in the rest of the country. And it doesn't look like that activity is part of the usual epidemic. So I'm guessing that we won't get, the usual flu hit till mid to late January at the earliest. So influenza is a common viral disease. There are epidemics that start in the winter and sometimes go into the spring. It peaks in late February and early March, and it's really predictable. It impacts 5% of the population every year. 5% of the population are going to get sick from flu each year. So most of us get it 1 out of 20 years. And the good news is influenza is like childbirth. You forget how bad it was. And so you start doing things like not getting a flu shot and thinking like you're not going to get sick, and then you get it again, and then, for the next 5 or 10 years after that, you say, oh man, I'm going to get a flu shot this year. That really sucked. But then you forget it again, and then another 5 or 10 years pass, you get it again, and you remember, because it reminds you. It's associated with between 30 and 80,000 deaths a year. I said associated with. 185 kids, killed 185 kids last year. 70% of those kids were immunized, and it's the childhood deaths that I think are most painful, because this is a virus that most people do well with, but some kids get pneumonia directly from the virus, and they get into the ICU and they die. And those are the hard ones, and those are what I think we're all trying to prevent. It's a quadrivalent vaccine that's between 60 and 7 and between 20 and 70% effective. Quadrivalent means it's vaccine against 4 different strains of flu. They figure this out by looking at what's making people sick in China and in Australia the year before. And they take the strains that are in widest circulation, figure that they're going to march from west to east, and they put them in the vaccine. So they start putting the vaccine together like in February and March of each year, and then they get it ready for distribution usually in August. We try to get the vaccine out in August, September, October, and November. And then the epidemic hits usually the following March and February. And the one other thing to know about the vaccine is, particularly in elder people, its effectiveness, when it is effective, lasts only 3 months. And one of the problems I have with sort of federal vaccine policy, I have had in my life screaming fighting matches with the head of CDC. Is CDC for some reason has been saying you can get immunized in August, which I think is just dumb. I get immunized at the end of November or early December because I want the vaccine to be effective when the epidemic hits. I don't care whether it's effective in September when there's no epidemic. I want it to be there and ready for people in February and March when the epidemic comes, but CDC, in its wisdom, hasn't gotten there yet. Anyway, they'll get there eventually, I suspect. It turns out to be most effective in 6-year-olds, who are the most contagious. So usually what happens is, or in many ways, the epidemic is a function of people's travel on Christmas and on Thanksgiving. It starts circulating in California, people start moving around the country for family stuff. Families get together on Thanksgiving and Christmas. A couple of the kids get sick, they take it to school, they spread it at school, and then it spreads from school to the rest of us. And the 6-year-olds rarely get that sick from it. The people who get sick are newborns up to 6 months of age because they don't get immunized, and people over 65 because their immune systems are not so strong. And as I think I mentioned a couple of days ago, it causes the pneumonia that ends up killing a fair number of people in the middle of the winter. So we don't give it to babies less than 6 months of age. It's inadequately effective as people age. So, people who are 80 and 90, they get a little protection, but not all that much. Our vaccination rate is now 37%. As a nation, it's never been greater than 50%. And some of us can imagine what life would be like if we could get to 75 or 80%, because at 75 or 80%, or maybe even a little more, you get something called herd immunity. When an entire population is vaccinated, usually with a more effective vaccine, that actually prevents disease from spreading from person to person, because if one person in a room is sick and everybody else is vaccinated, everybody else doesn't get it, and then everybody else doesn't spread it, and the damn thing stops there. But we are so far from that as not to be believed. And as I said, it starts in the west and moves east.
And so why is that? What's the controversies about getting vaccinated? Why do they resist it?
I have no blinking idea. I think they resist it because somebody's telling them to do it, as much as anything else.
It's the same reason why they get it.
The
Because somebody's
effective
telling
rate
them to
is
get it.
like sometimes 7%, it's very low.
Well,
It's not
it
working.
probably doesn't get lower than about 20%. It's not the most effective vaccine in history, and I get that. But it turns out to be the only thing we have.
As a
So-
healthy male, I think I could tolerate the flu better than getting a shot that I don't need with a lot of stuff in it that is dangerous. A lot of vaccine injuries occur.
Actually, when you actually look at the number of vaccine injuries from the flu, they are very few. And, like we said, there are lots and lots of people who actually get quite sick from the flu. I will often tell people who are about to get a flu shot, that they're going to get a little achy for a couple days, which is often the case, and sometimes they get something that feels like a cold. But let me talk about what the flu exactly is, and then we'll come back to this discussion for a second. Because the flu is, high fevers, fevers of 102 and 103 for a couple days, diffuse myalgias. People ache all over and really ache. What they typically say is it hurts to comb my hair. I mean, in my case, it's like, or it hurts to lift up my head. People feel like they've been knocked over by a truck. There's nausea and vomiting and sometimes diarrhea. There's probably a transitory viral meningitis, which accounts for why people feel so badly. They can get a viral pneumonitis that leads to staph pneumonia. And this happens for 3 to 5 days, but after those 3 to 5 days of what is really suffering, then you feel knocked over by a truck for the next 2 to 3 weeks. It takes people like a month to get back to normal life, and after a flu shot, like I said, you ache a little for a couple days. Sometimes you have a runny nose. The difference is night and day. And for those of us who have to work every day, to be out of commission for a week, and then feel crappy for another 2 to 3 weeks, as far as I'm concerned, it just isn't worth it. And because there is an association between flu and these 30 to 80,000 deaths, I mean, wouldn't it be nice if we could get everybody immunized and the flu didn't spread, and then we can test out whether those 30 to 80,000 deaths would go away. But I'm betting that a fair amount of them would, and I'm betting that very specifically because we dropped our vaccination rate last year, from 44 to 37%, and we pushed up our deaths associated with flu from 30,000 a year to 80,000 a year. Now, you can't prove there's a one-to-one association, but it feels like there probably is one. And one of the hard things, and one of the things I'm proud, one of the hard things is why that happened, and why I'm actually pretty excited about the neighborhood health station. It probably happened because all of a sudden flu became available everywhere. Once you start flu vaccine, once you started to be able to get vaccine in every pharmacy, primary care practices, which used to hound people to get the flu shots, stopped doing that because it just wasn't worth it for them. And so we, by expanding access in terms of number of places, gentlemen, I would like to interrupt to introduce you.
They know me. Doctor, how you doing?
Good. How are you? If they know you,
Guys?
we don't know how to thank you.
For what? For using the room here?
For using the room. This is Central Florida.
Okay.
We are learning together to do what's called mobile integrated care.
Okay.
So that some people who 911 calls, they get a 911 call, they don't have to go to the emergency room to be taken care of by the neighborhood.
Okay.
One of these guys has been so amazing.
So you guys all rescue or fire department too?
Yeah.
Both. Police? No?
No.
Rescue, fire? So none of those. You don't want those guys in here? Yeah, we don't want police in here. Hey, wait, my son's a policeman.
All right. He's all right.
So is there anybody working today? Is this the whole?
Yeah, these guys are working back.
Oh, okay, they're waiting for a call?
Yeah, they just came back.
So now how many meetings have you had?
We've been every day from 8 to 12.
Wow.
All this week, and we'll do that, we'll finish tomorrow at noon.
So a whole week worth of class. Yeah, good.
Yeah, they've been great.
Had some spirited discussions or what?
You can join this debate we're having right now.
Oh, we're having a
I'm
debate
curious to see
now?
what you
Yeah.
have to say,
On
'cause
flu shots.
we're not in agreement on it.
So what, your stance is yes flu shots?
My stance
And your
is flu
stance
shots
is
for
no?
everybody.
No?
I haven't gotten a flu shot in 30 years, I don't believe in them. So, you know, there's a lot of controversies, and I don't know if you want to touch on them. We'll go with your program if you want, but what works for me is no shot.
Okay.
I've never got a flu shot.
Man, you
Good to
guys.
have you.
I got the flu once though, a couple years ago. Yeah.
What was that like?
You know what, I ran over to the CVS Minute Clinic and got a Tamiflu, and I was not bad.
Okay.
Yeah. But I got the flu, I went over there on Friday night, I had the flu, took Tamiflu, and Sunday morning I was on a plane going to Florida to play golf. And I think I was like patient zero.
Yeah,
You know, I was
yeah.
sick in the plane, I think I infected everybody.
Yeah, well, just saying.
Yeah, I played golf on Sunday afternoon, so it was okay.
So you're the person I'm trying to change.
Yes.
You just tell me when and where I will come with that vaccine.
You want to give me the flu shot? Okay.
Let me get mine.
Yeah. So what's the percentage of people getting flu shots?
We're down to 37%.
Oh, we're down, it's come down?
It was 44% last year.
Wow.
And I was just saying.
It's guys like him that are talking everybody out of it.
I'm telling you.
No, I keep my opinion usually to myself.
But
Nice.
we also saw the flu associated deaths.
Okay.
The nation go from 30,000 to 80,000.
So was Rhode Island 37%?
And Rhode Island's usually better. I don't know Rhode Island.
Okay, all right, okay.
Rhode Island is somewhat better, but we are the best state. We have the best immunization rate for children.
Okay.
I'm actually offended that the Department of Health mandates that healthcare workers get a flu shot. You know, they require us to have one, or we have to wear a mask and all this other bullshit, and I'm offended.
So, tell us how you feel, but no.
Well,
So do you have to wear a mask?
If you don't get a flu shot,
You wear a mask
we're
when?
required, when we're on duty interacting with.
Are you a rescue or a
Yeah,
fire?
if
Or
we're
is
in
it
that-
the same thing?
We do both, so
Okay.
when we're interacting with patients, they're requiring us to wear a mask.
only when the virus is widespread in Rhode Island. So when the Director of Health declares that the virus is here and being transmitted, that's when all healthcare workers have to wear a mask.
Yeah, I think it's a scam myself.
Well, I'm probably the guy you should be mad at.
Did you start that?
I did. So we, anytime.
They'll talk after me. Yeah, when's it,
The neighborhood health station now looks like it's gonna be in the middle of January.
Okay, well, not bad.
But soon. I don't know if you've been by lately, but.
I have not been back yet, nope.
The parking lot, Alden Station is down, the parking lot is paved, so we're making more progress. Rather than- And this process
Yep.
is gonna be kind of the first of its kind.
So, what do you think, so how many rescue calls do you guys do a year, like, runs to the hospital?
About 42, 4,300.
4,300 a year? So what do you think would go over here? Would be half, or what's your projection?
Well, I think initially, we're probably gonna see one a day, so 300 to 400.
Yep, okay.
But, you know, I think what's yet to be seen is whether people start making better choices around the use of 911 and EMS
Yep.
once the neighborhood health station is open by itself, because it will be there, present, and people can walk to it.
So what kind of calls would you take over to Neighborhood Health as compared to going to Rhode Island Hospital?
We have a very specific protocol, but things like.
Anything what? What's that?
On the list.
Oh, we got a list.
We've
okay.
got a list of
Okay.
things like, you know, coughs and colds and allergies and headaches.
Okay.
You know, pretty simple stuff that most people would not use EMS for.
Are people calling rescue for that?
Take the drunks and the psychs, we could give you, you know, 80%, but you're not gonna take them.
up on that.
Yeah. But, you know, people use EMS for all sorts of stuff. Aches and pains, ran out of my pills.
Oh,
And it's
okay.
that kind of stuff that this is really.
Now, how many rescues do you have in Central Falls?
One part-time rescue.
One rescue. So what happens when that rescue's driving down to Rhode Island Hospital, there's another call?
Another community.
Yeah, somebody Cumberland,
Already.
Providence,
Communities.
Attleboro, whoever's available.
We're hoping to reduce the need for that.
Reduce the need.
And we've been working hard for the last couple of years, trying to look at people who use EMS a lot. And I don't know if you guys even know this, that everybody who's used EMS more than 4 times a year gets presented to a multidisciplinary team that meets here every Friday at 1:15.
Okay.
And we try to bring a bunch of resources to make sure that those people get substance use disorder treatment or get the psych treatment they
Do
need.
you see a lot of repeat people?
Oh, yeah.
Yeah?
EMS abuses.
Yep, and those are the people that we really focus on.
Yep.
They know the game, they know the things to say, to,
Yeah,
you know.
to get down there.
Yeah, go to certain hospitals.
About 3 years. And, you know, the evidence suggests that it actually has had some impact. That, you know, some of the people we used to use a lot, like there was such, we started first with a lady in her 40s with anxiety. You know, her primary care doctor didn't know she was using EMS a lot. We got them hooked up and she basically stopped using EMS.
This is primarily in the city?
Yeah, only in the city. So that lady had used EMS, I think, 30 times in a year, and it went to 0.
So who's meeting, who is it, yourself and who else? Who's in the room?
Around the table on Fridays, we have people from Blackstone, people from the Family Care Center in Pawtucket, people from a couple of mental health agencies, people from Anchor, people from the Housing Authority, you know, Community Service Unit, the police often come, kind of put our heads together, and we actually go through all the people at risk in Central Falls, not just people who have used frequently.
Interesting.
Join us sometime, it's really interesting.
What time is it at?
1:15 every Friday.
Yeah, well, they kick them all once in a
Right.
while. So good. Hey, guys, thank you. Thank you very much.
Thank you. Thank you
Thanks for
again
your,
for being here.
thanks for your service to Central Falls.
And
I
thanks,
love the city.
thanks to Navigant.
Okay, you're welcome.
For making
Thank you.
this happen.
Thank you.
Thanks.
Happy holidays, Merry Christmas.
Thank you. Okay, that was a break.
Who's that?
He's the president of the bank, President of Nashville.
Oh, I gotta see him about alone.
But no, he already knows that it's not, that there's no
It's got to
chance.
do with my pension.
Well, no. The way he's gonna set it up is, the only way he's gonna give you a loan is to get a flu shot.
Here we go, come on.
Anyway, okay. And just, I may have mentioned this before, but the pandemic of 1918, about 100 years ago, killed 50 to 100 million people around the world, 500,000 people in the United States. And it's probably one of the biggest, the most deadly natural disasters that ever happened in the world.
So have a lot to do with drinking water and septic systems and stuff.
No, I actually probably had to do with a secondary infection from staph pneumonia. But it had,
Probably get started a lot.
well,
Sanitary reasons.
there are many different contributing reasons, but certainly it was the flu that, and it killed that flu killed young people, not old people, and it killed them within days. And that's what we, are trying to make sure never happens again. When people get flu shots, just saying.
That 70% you said earlier that was vaccinated, out of that 70%, how many of those kids had medical problems?
Oh, you mean the vaccine?
That died.
The 185 kids who died?
Correct, and 70% were
Actually,
vaccinated.
most of them were previously healthy kids.
All healthy kids.
So I know a story of, a little girl from New Jersey who was 5 and basically needed intubation within 12 to 14 hours. And that she lived is still kind of half a miracle. She survived, but only by the skin of her teeth. This is a bad disease in some people. And, what we don't know is if we could really get most of the population immunized, 75, 80, 90%, whether we would substantially drop the death rate, particularly in kids. But we know last year, when the immunization rate dropped, that in a normal year we see 100 to 120 kids die. Last year we saw 185 kids. So the number went up. And, these are rough associations. But, my sense is that they're real things. And, we would all be better off if we could talk everybody, just saying.
I don't make that choice for my kids. I go with the experts like yourself that require it, but just like going to church on Sunday, I made a choice. And that's what I'm going with.
I respect it, but on the other hand, my hope is that someday we'll get enough people willing to be immunized so we get herd immunity and make this disease go away. The problem isn't just whether the one person or another is going to get sick. The problem is that when, in the 1 in 20 years on average, when each person gets sick, then they can spread it to other people. When that mean director of the Department of Health put in that regulation, it wasn't so much to protect the health workers themselves. It was actually to protect the community as a whole.
I get it.
Pain in the neck that the guy is. Anyway. So treatment needs to be started within 36 hours of the onset of illness. It reduces symptoms by about a day for most people. Costs $135 to $150. It's indicated for people with chronic disease and the elderly and kids with chronic disease. I tend not to use it very much because for relatively few people get there within 36 hours, and most people are, when they understand what it's going to cost, say not a chance. But it's there in case people need it, as you just heard. So EMS role is transport for respiratory compromise, for the frail elderly, for people with chronic disease or kids with disabilities, chronic disease or respiratory compromise, and is to help us, if you so choose, to encourage universal vaccination, because it's the message that people get from healthcare workers that turns out to lead what people themselves do. But it is a primary care condition in the absence of risk factors. Now, I want to spend a minute on patient assessment. And I think assessment and impression, because I think that's really how a certain part of the world turns. And I've asked Jared to help me with this because these are some of my own thoughts. And I probably need some input around what's okay and what's not okay from a sort of formal oversight perspective. But it's important to know when you look at public health, what data exists, which is not very much. We don't know much about the population of the city, of the state, or of the nation as a whole. We have really only 4 sources of data, and 2 of them stink. The first one are birth certificates, the second one are death certificates, the third are patient charts, and the fourth are EMS run sheets. EMS run sheets are very unusual because they are the only source of information about everybody who's used EMS. We don't have any information about everybody in the population as a whole except for them. So we know how many pregnancies are complicated from birth certificates. We know who dies of what, kind of, sort of, but as Dr. Gutman can tell you, the people who fill out death certificates are sometimes people in practice who've taken care of people for a long time, but mostly are the intern or resident on call who has known that person for the last 12 minutes and walks in, looks at the chart, and makes up something so they can let that person go back to sleep. They are not well thought out. This is what killed the person and is recorded on the death certificate. We kind of make it up, and then the nation compiles statistics based on that entirely crappy information. Each doctor knows about the patients they take care of, but only while they take care of them. So, if I want to figure out how many people in Central Falls have diabetes, I can ask to get information from the Blackstone record. But Blackstone takes care of 50 to 60% of the population. That means 40% of the population is taken care of by somebody else, and we have no way to get information about the population of the city of Central Falls together under one roof. We have no way to put that population together, so we don't actually know how many people have diabetes or how many people are smokers or anything else. We will know, and one of the great promises of the neighborhood health station is that if we can really enroll 90% of the population, we will be the first place in the United States where we can turn the clinical record into a public health record and start to learn things about this population and what are the things that make it sick, what are the things that make it well, what are its risk factors, and how do we improve those. So EMS run sheets turn out to be the best data we have about what's making people sick enough to call an ambulance. And that is incredibly useful data. And I'll tell you why. I'll give you just one example. A couple summers ago, because we look at the collated EMS run sheet data every month. Couple summers ago, we noticed that your runs for alcohol intoxication started to go through the roof in June. And we said, something's happening out there, what's going on? And it turns out that if you look at public health data from around the world, that there's evidence that shows that if you can shrink the number of open hours of alcohol retailers or bars and restaurants. Go ahead.
Come on. It's June, it gets warm out, they're sitting outside drinking, it's not rocket science. I don't think the liquor store being open till 10 really is breaking the bank.
So here's what happened. Let me tell you a story that I would have thought that too. But here's something we didn't anticipate. So we started saying, can we shrink the open hours? And we heard from the city attorney, no, you can't. That's controlled by the state legislature. And it turns out that the open hours go on June 1st from 9 in the morning to 10 at night to on June 1st, 7 in the morning till 11 at night. There's a state law extending open hours, it's called summer hours. And it turned out when we looked at it that Providence had noticed the same phenomena, and they went to the legislature the year before us and got the legislature to shrink open hours in Providence. And so we asked the legislature to do the same thing based on EMS run data. And we were able to picture it, they kind of got it. And so last year the legislature did the same thing. So our open hours dropped to 9 in the morning. Actually, they only shrank the early morning hours. So they went to 9 to 11 from 7 to 11. And when we looked at the run sheet data over the summer, your alcohol intoxication numbers, transport numbers in July, August, and September had dropped in half.
That's 'cause the
Guy
biggest
was
guys
Mark
moved to Pawtucket.
Mark Twain died,
That's
that's
a correlation.
Actually,
Yeah, but maybe he moved because the hours changed.
That's
I mean, during the morning, he had to find somewhere
but
else.
but it's looking at that kind of data
You
that
can interpret that data, and that's great. We could just shut them all down altogether. I mean,
well, but nobody's arguing that. You know,
there's people arguing about those hours because that was a big controversy because I believe it was a city ordinance before it was a state.
no, it can't be a city ordinance.
All right, well, whatever it was, I remember reading about it and hearing about it, and it's controversial.
The city ordinance was flavored tobacco products, the one that came down, and then increased the purchase age from 18 to 21. That
Yeah,
was the
there
big
was something
one.
about the hours of alcohol, I remember hearing about.
Well, there was discussion, you know, the city council had to support it, and they ended up supporting it, and, you know, we got to change. But it gives us the opportunity to look at stuff that's happening.
But that's,
And-
the underlying problem doesn't exist in the hours of accessibility, I don't believe.
Well, but there are a couple of things that in the public health world we call harm reduction, that actually gets fired by information that we find on EMS run sheets. And it's,
People read those?
you better believe it.
Wow.
And it turns out that the primary impression turns out to be really important, because we pay lots of attention to it, and we don't read each one, we collate them.
Yeah, I get you.
You know, we start looking for trends. And so the work you do is itself important, and then the way you record primary impression turns out to be really important as well, because that tells us what's going on. And you guys are the people with your eyes and ears on the ground, and you're seeing what's out there. There are other sources of data that are all survey data, but nothing that's real for every single person who's moved by ambulance. So it's pretty important. So like I said, we can change the law when we need to. We can go and recruit better resources when we need them. We, for example, figured out fentanyl death, that fentanyl was in Rhode Island. We figured those out from autopsies and death certificates. So Rhode Island was the first place in the nation to report fentanyl. And that happened because the medical examiner started noticing these rather a different pattern of deaths. She started testing. She actually brought the story to me when I was at the Department of Health. We called CDC. CDC sent an investigative team here, and that got published, you know, like in 2012 or 2013, and that alerted the nation to the presence of fentanyl, and that came out of this collaboration around data.
We're glad that you can use the EMS reports for these purposes, but know that every time you come up with something else that you want to put a study on, which is traffic and all this stuff, it's a tremendous burden on our care, because these guys are spending an in amount of time on reporting and documenting and less on care.
This is not to change reporting and documenting.
It does,
You know,
though.
I mean-
It affects what we do.
Well, everybody writes a primary impression, right?
Yeah.
And so all I'm here to do is to argue that the accuracy of the primary impression is as accurate as you can make it, just helps us get it
I'm
right.
just saying that in the years that I've been involved, the report went from being simple to being complicated.
Right.
And I don't think anybody considers what it does to us at this end, when you're at your level deciding what we need to document. The reports are out of control now. They take hours.
Well, you know, that's something that's happening across healthcare. And
I don't
that's
have to
something.
like it.
Yeah, I don't have to like it either, and that's something that a bunch of us are trying to sort of stand up and change. Anyway, so, you know, being precise in the impression helps you when you think about it with patient care decision making. Because if you know, sort of think about it in a precise way, you're going to communicate it to your medical control precisely, and we're going to get the resources you need. It helps with billing, but the thing I don't quite understand is that even in the billing world, and this gets to your point, they're asking you to use diagnostic coding, what's called CPT coding. And I don't understand how we can be asking EMTs to do CPT coding because we're not asking you to provide formal diagnosis. So I don't see how you do one without the other, and that's something that I've heard from a bunch of people that I think all of us need to find a way to change. But it really helps us track the incidence of disease, what's happening where, so that we can bring resources to bear when we need them, when things start to change, as they will. So, in terms of assessment and impression, the first question, and I think Dr. Pacheco said this yesterday and said it beautifully, first question you ask yourself is sick or not sick. That's a major question, and that's going to decide a lot about what you do. How sick, you decide what's first and what's next, and then you use whatever you call it to help recruit the resources you need, and then you write down an impression that's a working diagnosis that will guide immediate treatment and help us with population analysis. So the more precise you can be, the better off we are in terms of helping get you the support that you need. So precise as you can in a few words, and use the presenting symptom when you don't have enough information to help you form a working diagnosis. I mean, your best guess is going to be a way better guess than most everybody's. So impressions that matter, and Jared, please feed this back because I sort of made up the language. Likely opiate overdose instead of unconscious, likely alcohol intoxication instead of unconscious, likely hyperglycemia, if you've got a blood sugar of 500 and it's a patient with diabetes, COPD in exacerbation, if you have somebody who's a smoker who's wheezing, bipolar disease with evidence of mania, if you know somebody's bipolar and they're jumping through all sorts of hoops, crushing chest pain in a patient with heart disease, even sore throat or productive cough or wheezing in an asthmatic. Yeah, it's a tough one. To me, these are impressions that really help us with analysis. Jared, does that ring true from your perspective?
They do, and the problem with the image trend reporting is a lot of this stuff isn't spelled out in the impression, so a lot of times what happens is you end up trying to find the closest thing to it, and it sometimes ends up being unconscious person because that's the closest to it, and then you put it into your chief complaint, you can explain it a little bit more.
Right.
Chief complaint is suspected opioid overdose, and then with your impression ends up being they're unconscious.
Right, and I think we would benefit from seeing, if you're in your chief complaint it's an opiate overdose, to show it in your primary impression as an opiate overdose is a little more precise than unconscious. And so conversely, impressions that matter a little less, unconscious, psych, shortness of breath, chest pain, fever, pain, fatigue, that may be all you have to work with, and we get that. But if you have something more to work with and can be more precise, that's going to help everybody. And particularly, when we see lots of bad disease, help us recruit the resources we need to get you guys better support. You may not know, for example, that as a result of the work you've done and reporting you've done around opiate overdoses, we have a team of people who goes to the house of everybody who's overdosed and tries to bring them information about treatment and about recovery and about, sort of making sure their families know about how families can get support. And that's based on the work you do and the information you've given us. So your impressions may trigger a call to CDC. They may trigger closing of schools at some points, change in state law or new zoning ordinances, or an immunization campaign. Prophylaxis of an exposed population. So, if we get somebody who's described as having meningococcemia, we're going to make sure we get very quickly to everybody who's been potentially exposed and get them on rifampin. Sometimes reports have caused the closing of a bakery or a nursing home, because if we see a bunch of reports coming from the same place, that begins to sort of start the whole public health process. And it certainly will help us make people in Central Falls healthy and safe. which is what rules. So let's take a break for 5 minutes, and then come back for Dr. Getman.